I now invite Dr. Elizabeth Joseph, HOD of Ophthalmology, Little for Hospital Angamali, working there for more than 40 years. And she is a well-known surgeon. Now she is elected as the Vice President of Strabismological Society of India also. Yeah. Nominator. Okay, over to Dr. Elizabeth. She will be talking on the amblyopia caused by media opacities or deprivation.
Good morning, everyone. My talk is on stimulus deprivation amblyopia. Stimulus deprivation amblyopia develops due to an obstruction to the clear passage of light, preventing the formation of clear image on the retina. Conditions like congenital cataract, corneal opacities, ptosis, hemangioma of the lid, vitreous hemorrhage, occlusion amblyopia, uncorrected aphakia are all causes of stimulus deprivation amblyopia. Actually, stimulus deprivation amblyopia is very severe and is resistant to treatment unless it is tackled very early. It contributes only about 3% of all amblyopia. This is also known as amblyopia X anopsia. Both pedig and infant aphakia treatment studies have shown that deprivation amblyopia is comparatively rare, comprising of about 3 to 4% of amblyopia. And even after excellent standard of care given in this various studies, the average visual acuity achieved in children with the monocular deprivation is only 20/160. That means deprivation amblyopia is very difficult to treat. Good outcomes occur only when there has been both early treatment and extensive patching. And so these characteristics underscore the severity of monocular deprivation amblyopia and distinguish it from other amblyopia. The best way is the prevention. Best way is to prevent a stimulus deprivation amblyopia. And how to prevent? It's only screening. Vision screening programs. In the neonatal nursery, when the child is born, the pediatrician or the neonatologist has to look at the eyes, look for the red reflex test, do the Bruckner's test with the direct ophthalmoscope. If there is any congenital cataract, immediately refer. That is the best thing to prevent development of deprivation amblyopia. Also, from 3 months to 2 years, less than 3 years, you have to have a periodic examination of the eyes of the children. The pediatrician should be aware and should know how to do a Bruckner's red reflex test, and immediate referral is the way to prevent deprivation amblyopia. And one thing everyone should know is about the human critical period of visual acuity development. If the visual development is interrupted in the critical period, there will be amblyopia. And human critical period for visual acuity loss is only 6 to 8 weeks of life in conditions like congenital cataract or corneal opacity. And in squint, we have little more time, maybe 8 to 12 months or even up to 2 years. If the squint is treated before 2 years, you can get some amount of binocular vision. But if it is treated, fully corrected before 1 year, you can have a perfect binocular vision. And the stages of treatment for deprivation amblyopia, first and foremost, correct the causative factor. Like treat the congenital cataract, treat the corneal opacities like that. Correct the causative factor and then prescribe any necessary glasses and continue with occlusion therapy and other specific treatment. The younger the child, the better the prognosis. Deprivation amblyopia, again I say, carries the poorest prognosis. Strabismic amblyopia has the best prognosis. Hypermetropes have poor prognosis than myopes because myopes can see at near, and so there will not be much amblyopia, but hypermetropes are not able to see for near and distance. And occlusion therapy is still the primary management of amblyopia. See, in unilateral congenital cataract is the most common type of stimulus deprivation amblyopia, and surgery has to be done before 6 weeks, and then intraocular implantation later and contact lenses immediately. See, this is a child whom, it's a 14-year-old girl whom we picked up in one of the camps done in Idukki district. This child had bilateral congenital cataract and was not getting any treatment, and we picked up the child and did surgery. And even after surgery, the vision did not improve much. The vision was only 2/60 or so. The patient had severe deprivation amblyopia. So that is the problem with congenital cataract. Has been done early. If it is done late, there won't be any use. Congenital corneal opacities, the corneal transplantation has to be done in the first few months of life. So this is a child who had a bilateral congenital corneal opacity. We did a corneal transplant in both eyes and the child is seeing. And again another child presented with the esotropia, and when we examined there is a cataract too. That child underwent cataract surgery first and then squint surgery. Congenital glaucoma has to be operated in the first 2 weeks of life. And when you think about stimulus deprivation amblyopia, apart from the causes I already discussed, there may be other causes. The eyes may have coexisting pathology like microphthalmos, optic nerve hypoplasia, coloboma, etc., where it is very difficult to differentiate how much defective vision is due to amblyopia and how much is due to the structural program. So I again put another slide. This child was in the blind school. When we did a blind school study, we picked up this child. This child also had congenital cataract. In spite of we ophthalmologists working in this state of Kerala, such an affair is still present in our country, in our state. This is one child who had congenital cataract. We picked up from blind school. Severe deprivation. Even if you treat, even if you do surgery, deprivation amblyopia, you won't be able to do anything much. And coming to the patching regime in deprivation amblyopia, it is more strict than the strabismic amblyopia. In older children, you have to do 50% of the waking time patching, and in younger children, depending on the age of the children, a 1-month-old child, 1 hour occlusion, like that. And after that, you can give some active stimulation like this. And there are so many other methods of stimulation. In the younger child who is not able to do any dioptic therapy, you can have stimulation with cards like this. And in older child, you can give all the vision stimulation exercises, computer games, etc. And dioptic therapy is very popular now. The Binox is there, the IBIT system is there, the Revital, all these things I think Dr. Sanitha will be discussing. And I would like to share with you our experience with Binox. Binox is a dioptic therapy in which both eyes are used simultaneously. It is more effective in deprivation amblyopia than in strabismic amblyopia because bifoveal fixation is necessary for this. In the last 2 months, we tried Binox in 12 patients, and 3 patients showed very good improvement. And all these 12 are failed occlusion failed patients, and they had anisometropia, and all of them were older people, older children and young adults. In older children older than 9 years, and even in young adults, if there is a amblyopia, you can go for this treatment by a dioptic therapy, which can be done at home, and it is cloud based. And I want to add one word about future treatment. See, whatever said and done, we are not happy with the current state of affairs in amblyopia treatment. Often we fail, so we are looking for new modalities, and now the current modalities are highly unsatisfactory. So total retinal inactivation of the good eye by an intravitreal injection will result in the deprived eye to start working. This is the new concept of amblyopia treatment. You give injection tetrodotoxin to the good eye, so that good eye is shut down for about 12 to 48 hours. And when the good eye is shut down, the deprived eye, the stimulus deprived eye will take up. This is still in animal stage. I think this is the next thing to go. Thank you very much for your patient hearing, and thank you, Dr. Andreas, for giving me this opportunity. Thank you very much.
Thank you, Dr. Elizabeth, for throwing light into the future of amblyopia management.